So you move from, considering the RPFS data, the OS data, and this, progression or prevention of progression symptomatically. How do you, maybe with Dr. Fizazi and others at Gustave Roussy, approach the question of who is the right patient for radiotherapy when presenting with de novo metastatic disease today, based on what we know?
Yeah, this is a $1 million question, of course, because it's not easy to for the data we have up to now. Of course, we are going to dig into that in details further on before the publication of the paper related to this. But indeed, the question of clearly identify patients that may benefit from local radiotherapy becomes a very important question. If I may, Chris, I would like also to add that we have also analyzed the secondary endpoint of the trial, which was the onset of the castration-resistant state for those patients. And then you are probably aware that even in this secondary endpoint, we could show that radiotherapy on top of standard of care plus or minus abiraterone added a significant delay in the onset of the castration-resistant free survival. And again, we could show a significant impact of a sort of effect due to abiraterone plus radiotherapy in this endpoint. So to answer your question, I would say that if you take into account both these results, which may impact the quality of life of our patient, I guess that our results may enlarge the group of patients that may benefit from local radiotherapy in this setting. How to define them better, it's probably a little bit too early to answer as far as our data are concerned.
Right, and putting it together with Stampede, you're thinking a wider subset of men with higher volume of disease may actually benefit, maybe not with their survival endpoints, but with these symptomatic endpoints and other surrogates of progression.
Sure. Chris, we all see those kind of patients. I think it would be very, not a very good idea to only concentrate on overall survival benefit. We know that those patients may present with a dramatic local bulky disease. We know that they may have metastases around. And I don't know what is your experience, but after COVID, at least here in France, we see those patients more and more because diagnosis was postponed. So we can now tell them, if you believe in our data, they may be at least two very important, even three very important benefit in terms of RPFS, but also in terms of quality of life, as I showed you. So as you said, I really think that from Monday morning, my message would be, you may enlarge the indication of those patients. Of course, if you are sensible to overall survival benefit, which I'm not at all against, of course, and you have a low volume patient, then radiotherapy follows Stampede may be still recommended. But I don't have, Chris, this impression that the results of our both trial are one against the other. They may complement our package of treatment that we can propose to patients, but I'm probably a little bit too optimistic on that, but okay, that's my position.
Well, I think it's good. I think it's, it's all about your mindset, right? It's a nice sort of synthetic rather than adversarial approach on the data. So you kind of alluded to this. Any other sort of specific thoughts or plans or things that you think the PEACE-1 data set can offer to help us understand treatment for patients with mCSPC?
Well, we went very in details also in the toxicity, for example, of radiotherapy, because this may be a good question. Come on, you propose radiotherapy to a patient. Okay, I understand that you may have this benefit, but what about toxicity? Are we adding some form of toxicity to our patients? Well, this does not appear the case. At least in our numbers, there is no increased toxicity when delivering radiotherapy, even for the most classical radiotherapy side effects. For example, the one in the gastrointestinal domain. We have not seen more rectitis due to radiotherapy. We have not seen rectal hemorrhage due to radiotherapy. This, I guess, is also reassuring for our patients and their families. It's not, a terrible treatment that may impact on their quality of life in the short term. I also have to tell you that if you consider what kind of schedule of radiotherapy we used, in terms of biological effect, these may have been a little bit higher than what Stampede has used. Is this what may explain this effect in terms of local beneficial effect of radiotherapy? Of course, I don't know. This is just in pure, thinking I may have, but this is something that at least the radiotherapy community should be familiar with.
Absolutely. And I'm maybe going to ask you questions beyond the piece one data, and so maybe it's not quite fair, but when you look today at what we know based on trials that have happened in the localized disease space, you alluded to this before, would you use a similar fractionation schedule for a patient you're treating now, or would you apply like a moderate hypofractionation approach in this setting when you're actually treating your patients, just sort of inferring the piece one data, but using a different actual schedule?
Yeah, that's a very good question. Probably if I would have designed now the radiotherapy schedule for piece one, I would have, gone for a more hypofractionated schedule. We have the data of the English data coming from the CHEAP trial, David Durnley, showing us that there is no difference in terms of the major endpoints when you use an hyperfractionated regimen. So why not? And of course, the less you oblige your patients to come to your treatment, the better it is for his quality of life. So for sure, I would go today for a more hypofractionated regimen. But again, at that time, 10 years ago, I believe you understand it was not that easy to have our French colleagues, convinced that this was the way to go.